Welcome everybody to the seminar. This is the second installment of the special EDI session. And we're delighted that our speaker today is Nathaniel Osgood, who will be speaking about dynamic modeling and health inequities. Nathaniel is well known in the modeling community. He's a professor in the Department of Computer Science at the University of Saskatchewan. His degree is from MIT. And as I said, a well-known and well-published author in this area, and somebody whose opinion we value and consult often when we want to figure out what's going on. So Nathaniel, please.
Thank you so much, Kumar. Thank you to Sarah and others who have helped make this event possible. It's a real honor for me to be here to offer this talk. I did want to be sure, because I know it was a priority, that recording is on. I see that it is, despite the recording button not being depressed. Okay, so this talk is a special one for me. Some of you know me in quite different capacities. Some know my work in agent-based, hybrid, and multi-scale modeling for infectious diseases and other areas. Others of you may be familiar with our work in big data and leveraging big data together with machine learning and computational statistics techniques with dynamic models to advise across all provinces through PHAC, or for six provinces for First Nations reserves throughout the COVID-19 pandemic, and before that through leadership of my student Xiaoyan Li, with pertussis and measles and pandemic influenza and other conditions. Others yet may know me as the creator of several generations of data collection system, such as our Ethica health system, which is used worldwide in hundreds of studies for epidemiological data collection, including sensors and self-reported information. There's a few here who will know me as someone who is working to combine applied category theory together with dynamic modeling, and particularly for health modeling. You could be forgiven if you're aware of several spheres of my domain for thinking these are fragmented and almost bizarrely disjointed from each other. Far from it. Today's talk, I'm going to be pointing to an overall theme, an overall motivation, an overall impetus for these disparate lines of work, something that drives our choice of application areas, something which drives our investments in methodology of my computational epidemiology and public health informatics lab. It has to do with the entanglement of multiple health issues, what we call syndemics, and their entanglement with social justice issues, issues of social concern, and issues that often make their way into community safety, well-being, and even education areas. So within this talk, and I'm going to switch to my slides here, I'm going to be providing a prioritized coverage of a set of materials. I'm going to briefly recap the importance of applying an equity lens here within an infectious disease area. This will recap but build on some comments from Professor Mishra in the session, the last session within this series. But from a system science perspective, I'll be making some additional points. Secondly, I'll be offering by request a set of vignettes, 3 if time allows, which illustrate for me the importance, the relevance, and the critical need to examine equity issues within matters of infectious disease. And 2 of them are in the sphere of COVID-19 spread and came up during my secondment for 13 months to the health system, along with many in my lab. A third one will be on infectious disease in the waterborne infection area, but also involve its interaction with chronic diseases and indeed education outcomes for children. I'm then going to focus on the interaction of a multi-decades-long ripening of awareness and understanding of how to conduct work in a participatory fashion, a community-based fashion often, involving those with lived experience that goes by many names. Patient-oriented research, participatory action research, community-based participatory research. It goes by many names, but they consistently involve those who are affected by decision-making to be informed by the research in shaping, in conducting, and helping to translate, helping to interpret and disseminate that research. And what I want to highlight in this section, though, is looking beyond that general tradition, rich as though it is, and important though it is that I highlight resources to you. I want to highlight how it's been applied to modeling in spheres that are probably outside the awareness of this group, and how there's a rich literature that's developed on use of participatory modeling approaches and group model building approaches that is decades in its formulation and that can be applied more or less directly to infectious disease, communicable disease models, such as those used in COVID-19 and diverse other communicable conditions. Those techniques are particularly applicable for addressing the sort of equity concerns that I'm going to be hitting on these vignettes. Now, as time allows, and I fear that it won't, because I want to prioritize time for discussion, I may include some comments on the impacts of model structure and architecture, the scope of that model, what it includes in terms of heterogeneity, on equity, and both risks and opportunities within that sphere. That might be best suited to be another talk, and I think it's likely I won't be able to materially cover that today, other than to give a nod of how important an issue it is to us as modelers. I'll then leave you with some thoughts on principle and some take-home points. Okay, so a large motivation for this talk was to address some what I consider common myths and cherished prejudices. Those who know me well will know that I'm not one for valuing shibboleths and adhering to tribalistic boundaries. I'm one that crosses boundaries, perhaps to a fault. Within this sphere, I've noted that there's a certain number of prejudices that I encountered, not only in the infectious disease modeling area, but especially prominent within it regarding the sorts of methods I'll be talking about. Ideas that look, community members and those with lived experience, people without high school education, much less college education and STEM fields, it's not really possible that the myth goes for them to meaningfully engage with a model. Models are technocratic activities undertaken by experts, and population members, while we're trying to help them, really have no business getting involved in the modeling sphere. Another common myth or prejudice is, this talk about involving community engagement and modeling, it's a nice gesture. It's sort of a feel-good gesture, but it's too fluffy to really undertake with a rigorous mathematical model. Maybe it's in tension with model rigor or sophistication, or it's too time-consuming to seriously contemplate. There's a notion that it's, community engagement is this unstructured activity that just goes on and on and on, doesn't sort of circles around, it doesn't really go anywhere. And we need to make progress and get our models out quickly to advise on pressing issues. And finally, there's this notion that, this talk of EDI, this talk of considering equity, it's all nice and good. It's politically correct and it's kind of feel good. It's about us, holding hands and singing Kumbaya, but it really is not where the action is. It doesn't bear on model success. It's a fluffy addition. When we got to get work done, it gets in our way. And those are cherished prejudices that I believe need to be put aside. They are quite prevalent. they are problematic. And I think ultimately they're at great disparity from the truth, as someone who has practiced participatory methods now for dozens of years. There's also a notion that models benefit from hard data. Give me the numbers, not some sort of fluffy qualitative understanding, not some sort of discussion from focus groups, not some sort of narrative. Give me the numbers so I can plug them in, I can calibrate to them, and I can validate off of them. That's sort of the notion there. And I think also that misses something big. And finally, there's a notion that, at the end of the day, when we consider COVID-19, or we consider TB, or we consider, antimicrobial resistance or STIs or what have you, we should focus on the core disease at hand. And while it's intriguing intellectually to contemplate crossovers to other conditions, living conditions, social conditions, that these areas don't really get to the heart of the matter. They don't bear on infectious disease transmission and the health system load. And I think the truth, that could not be further from the truth. I think we increasingly have to deal with these messier, broader issues. And I'm going to try to make a case for that. Sharmistha last week, Dr. Mishra gave a remarkable set of motivations for applying an equity lens. And I can't do justice. You could consider my talk but a candle to her son. And like everyone involved here, probably I find myself learning so much from her talk. But from a system science perspective, I did want to offer my sort of bit on it. There's a moral indefensibility, I believe, as we're trying to build a just society to tolerate health disparities and to tolerate the issues that drive them, the injustices or inequities. But, it should rest on all of our consciences that so much of this results from and is associated with burden in those who are most innocent, those in childhood, those who are born into families in adverse circumstances. And adverse childhood experiences have mammoth impact on lifelong impacts we've known for decades and decades. There's a further conviction from a system science perspective, as articulated by UN Chief Antonio Guterres, that none of us are safe until all of us are safe. And I believe when it comes to infectious disease, we need look no further than the Omicron variant to realize how true that is. But there's something beyond that as well. Inequities breed inequities. They breed distrust. They breed disengagement, disenfranchisement that inevitably yields to further disparities in health, inequities, and further breeds these destructive attitudes that corrode the very civic fabric of our nation. Also, we're faced with the fact that in the age of COVID-19 and indeed Omicron, a chain is only as strong as its weakest link. If there's a disproportionate impact on a vulnerable segment of the community, whether it's the youngest children or those in long-term care facilities, there's a very real risk that our health system will be overwhelmed and burdened to the point of impairing everyone's health. There's this pervasive impact of one condition on other conditions unless we get everyone's health secured away. Everyone's health is dealt with as a human right. I'll pause my comments there, but I want to zero into, infectious disease. Those are broader comments on equity. Communicable disease. If we think about equity, rather than asking where does equity interact with infectious disease, I think we need to really ask where does it not. It affects everything from time of presentation to care, fear of being stigmatized when one presents, inability to access their care because of transportation barriers, et cetera. Willingness to cooperate with contact tracing, willingness to get tested, ability to isolate or quarantine if one's living with 15 other people in one's house. There's a lack of meaningful capacity to engage in such behaviors, isolation or quarantine. Reporting of test results. There's a wide belief right now that within the health system, that a lot of positive test results aren't being reported because people don't want to be a party pooper. And there's social norms associated with that support that behavior. This also impacts, of course, the burden of chronic diseases and risk behaviors, such as smoking, the occurrence of poor nutrition, sedentary behavior that worsens symptoms and sequelae of these diseases. And if we zero in on vaccination, we see countless cases of this documented as some of the foremost issues in the literature. And I provided, for those interested in going deeper, some references down here. Focused on barriers in minority communities, particularly, whether it's transportation, lack of affordable childcare, other caregiving responsibilities, mobility barriers due to existing poor health, whether it's issues of the digital divide, meaning that people don't have the smartphones that will allow them to install, the vaccine passport apps or to get easily registered for vaccination appointments. There's countless issues that are getting in the way of people in lower income communities being vaccinated. I want to highlight this because in the vaccination area, there's a certain normative feel to a lot of the discourse that, if people just, pulled up their britches and got vaccinated, if they were socially responsible, we'd be done with this pandemic. Is the idea I sometimes hear, and a lot of impatience and a lot of sense that this is willful ignorance or deliberate shirking of civic responsibility. And there may be quarters where that opprobrium is not off base, but for so many individuals who are in that low SES components, it's about these barriers. And the barriers are different in rural spheres and urban core areas and in areas of people with adverse health conditions, those at risk of neighborhood safety issues, et cetera. And this is well documented in the literature. This is not something that I'm conjuring up. It's well documented in these reviews if anyone's interested in going into it. So let's talk about some of these vignettes. So this was something I was asked to give perhaps more than anything else in this talk. And I want to talk about these vignettes because I think they're eye-opening. Two of the vignettes took place as part of my secondment, as part of our modeling partnerships with the Saskatchewan Health Authority, the Government of Canada, which have now extended to Yukon and Alberta Health Services, and to the Australian Capital Territory, where our model was used as the primary modeling tool for COVID-19 planning. This is a geographic specific ABM modeling province-wide populations or statewide in Australia. We have geographically situated communities with workplaces, homes, schools, hospitals, persons. And my student, Wade McDonald, who's on this call, contributed this model with incredible prescience, building a structure that has lasted to this day. There's many components of the model I'd love to talk about. The nerd in me would just love it, but we don't have time to do that other than to say it's a very detailed and spatially explicit model that deals with great heterogeneities and barriers that of many sorts for effective COVID-19 outcomes. The model is built in a fashion that is visually accessible, very important for the processes we'll be talking about later, so we can engage with ongoing discussion with stakeholders and get them to point out missing components of our model, cherished assumptions that just ain't so. And there are some blatant factors such as risk attitude that cut across multiple areas, such as mask use, gathering participation, and likelihood of working from home. And I believe perhaps it's been expanded to vaccination as well. So the first vignette uses this model in the Losh Clearwater River Dene Nation, two adjoining communities in northern Saskatchewan that bore the brunt of one of the earliest outbreaks within our province, a devastating outbreak for the community until it could be brought under control through community efforts, in part motivated by findings from this model. Key equity issues in this community cannot be overstated. This is a community where the number of people per home in a, say, a 2 or 3 bedroom home varied from about 10 people per home, I believe, in the Loch Clearwater, to about 15 people per home in Clearwater River Dene Nation. One could imagine the air quality, the ventilation impacts of this, and the broader impacts of such adverse housing are well documented as well in the literature. Within this community, though, as well, there were a set of other issues of profound significance for COVID-19. In terms of isolating people in community cohort facilities, caregiving responsibilities within a family often bore on the inability, prevented that. There's a set of challenges that the community faced: homelessness, substance use disorders, mental health challenges, that greatly complicated intervention, effective intervention formulation. The role of schools was totally different. Where schools we think of as providing education, but so much of what they provided in the community was much more than that. It was social services, health services, safe food for children, nutritious food, a safe environment from homes, caregiving during the day, education, to be sure, but countless other important elements to the community that meant closing it was the last resort. Homelessness was a major issue of the community and led to unrestricted gatherings, limited access to sanitation on the part of those who are some of those at most risk of transmitting it, and risk of spread to homes where people would squat overnight and couch surf among relatives. And within this sphere of homelessness, much of it was coupled with issues of substance use. And once again, that led to violation of quarantines. It led to gatherings outside the liquor store and in the vicinity of liquor availability that again got in the way of safe COVID-19 management. This is a community where there's comparatively limited local care resources, and where the community faces a very high burden of chronic disease outcomes, largely due to historically forced settlement that deprive people of traditional routes for good diet and physical activity by enforcing settlement where they had for millennia moved around the broader landscape. And this led to high rates of chronic conditions that led to the need for the imperative of medical taxis. These medical taxis, to give a sense of the risks, would have to drive with passengers, potentially COVID-19 infected driver and passengers, for 3 to 5 hours, multiple times a week, for things like dialysis clinic attendance for a given patient. You can only imagine the risks associated with infection spread within a small vehicle because those care resources weren't available in the community. The distant nature of the community meant that there was limited availability of testing, and diagnoses were long delayed compared to other communities. Patients would have to be evacuated into major cities without a family often being able to care for them. And all of this, of course, led to big outbreaks that in turn led to, and this is the thing that should be shocking to everyone, a community facing a systematic disadvantage through decades of, or really centuries now of marginalization and systemic racism, led to stigmatization because it was the source of outbreaks, led to blaming and name calling by those elsewhere in the province for this community as if it were to blame for the outbreaks when they resulted from such equity concerns. Within this project, we had representatives, community stakeholders who provided, and model results were provided back and forth to the community for feedback and for sharing. We were interacting most directly with local medical officers of health from a variety of conditions. I'm not going to be able to comment for time on some of the details, but we looked at a wide variety of elements of community context that were captured within our detailed models of this community. Wade did an amazing job adapting it to the community, even for such things as worksite risks, the delays associated with test results, the acute care flows that had to be flown out, and availability of resources such as door-to-door screening teams, et cetera. And there are a variety of community-specific scenarios that we ran through guidance from community stakeholders and the medical health officers. What this showed to us was the incredible importance of local context for informing the questions that were important to ask and the questions that need not be asked because they could not be changed. Questions involving school closure, for example, were almost off the table. And it led us to a framework where, hey, look, if we can't close schools, let's figure out how we could partner with the community to have the greatest impact, given that schools have to remain open. And this was a watchword of later modeling with other communities and other organizations. A lot of other things I'd love to note here, but I do want to emphasize the importance of relationship building and trust building through respectful dialogue with community members from whatever background or community stakeholders. The lead on this was Wade McDonald, as with another vignette I'll be showing. And really, he made essentially most of this modeling possible in the vignettes. But I do want to thank the Saskatchewan Health Authority and their Ministry of Health for also making that possible, including Andrew McCletchie, the lead for the North, the VP for the North, Jenny Basran, and others. A second vignette is from Hutterite colonies. And once again, ladies and gentlemen, this is a story of stigmatization and blaming coming out of high-risk circumstances, of outbreaks coming out of high-risk circumstances. Hutterite colonies, for those not familiar with them, are scattered around the broader prairies in both the US and Canada, and Saskatchewan has dozens of them. What's notable is that these colonies are not solitudes. They're linked in with networks associated with often founding of one colony by another. When colonies reach a certain size, they kind of subdivide and members go off and form new colonies. And colonies therefore vary within certain defined size limits. These colonies are of multiple, have different networks, and there's three major groups that are largely circulate separately. Although they have a certain shared set of beliefs, they are in different lutte by which they engage and interact by exchanging people, marriage partners, work parties, etc. And these parties, these colonies bore the brunt of a wave not long after La Loche Clearwater. And this article appeared in the Western Producer, aimed at predominantly rural farming audiences, noting they're bearing the brunt of the COVID-19 pandemic, and they ascribe it to the single community living, communal living setting associated with these communities. And this outbreak spread across multiple communities and was linked most immediately, most proximally, to a large wedding that had taken place over the border in Alberta with about 1,800 people present, who then dispersed to the various home colonies. Excuse me, it was not a wedding. I speak grievously. It was a funeral for the tragic drowning deaths of three Hutterite girls that happened to occur during the pandemic. And it was in that mourning process that the communities were members were themselves exposed. So there's profoundly different contextual issues. This is very different from our traditional settings, probably of most familiarity to those on the call. But it's also very different from the northern communities we talked about. It's a very communal environment with kitchens that are shared between all families, dining areas shared between all families, very close packed church services, frequently and long attended, large family units, close work groups that work together, and comparatively high chronic disease prevalence. Elderly are in families, they're not in specialized long-term care facilities, and there's a lot of exchange between different colonies. And colony members go back and forth to major cities for things like medical needs, farmers markets, etc. So key equity issues here relate to particularly the otherizing of these communities. People will sometimes think of these communities as kind of outdated, curiosities that dot the landscape and look down on their different ways and their, the different languages that they speak. There's a fair degree of stigmatization that comes through this. And this came through in a big and defining way in this outbreak. There's distrust that's built up, partly because of that stigmatization within the communities. There's a fear that outbreaks within the community, the dirty laundry from the community, if exposed to the outside world, will give the community a bad name. It will disadvantage the community. It will make it a place people don't want to go to do business or won't want to engage in business transactions. So a lot of these colonies are very effective business partners, quite prominent in the rural business landscape. Therefore, there was real limited willingness to report symptoms, be tested, perform contact tracing, allow MHOs to perform contact tracing, or public health nurses to perform contact tracing, and a real hesitancy and delay even in care seeking, which meant that when people got sick, they wouldn't show up until they were grievously sick and at highest risk of needing hospitalization and even of passing away. This in turn led to more stigmatization. And I need to tell you a story. I need to tell you a story of stigmatization and disadvantage that was probably the single most dispiriting occurrence I encountered during my 13-month secondment. We were working with the communities, these communities, helping to advise them, including with people with lived experience on our team who are advising them and guiding the modeling. We felt that relationships were being built up, but something terrible happened. And it was a mark of the political vulnerability of these communities. And it's something that both validates the fears of stigmatization and worsened it. A public health order had been involved for these communities, and a public advisory had been issued to warn members of the public about outbreak risk at many communities throughout our province, Saskatchewan. That public health order advised caution when circulating in certain listed communities. Many of those communities were Hutterite communities. Some of those communities were Indigenous communities, but quite a few of those communities were neither. They were settler communities, as it were. They were communities of, in the broader population. And what happened is that certain members of the government, certain MPs, got a hold of this public health advisory and intervened to have the names of their communities removed from the advisory. Representing those communities, they didn't want their communities to be disadvantaged. The communities' names that were removed were not Indigenous communities. The communities' names that were removed were not Hutterite communities. The names that were removed were the broader populations communities that were well represented in the corridors of power. The communities that remained in that public health advisory saying, watch out when interacting with these communities, were predominantly Hutterite and First Nations communities, because they were the ones who were not shielded from the public opprobrium. And as a result, more blame was placed on these communities. Look, it's a Hutterite problem. Look, it's a problem with Indigenous communities. When we talk about stigmatization, it's not something abstract. When we talk about marginalization, it's not, a nice academic concept. It is real, it is pervasive, and it can be profound in shaping the evolution of communities and the health of our broader society. So this was a community that we worked to adapt our model to, representing intercolony mixing, geographic relationships of the colonies, the gatherings among affiliated colonies, and movements back and forth to the urban centers. And it was guided by by one with lived experience who helped guide the modeling and who helped inform the modeling assumptions, including parameter values, and help advise the MHOs involved. Very important. Unfortunately, one where political apparatus ended up interfering with the benefits. Time is running on. I'd like to finish up with my last vignette on the Yellow Quill First Nation. This was work that wasn't on COVID-19. It was on waterborne illness, but it came to involve many other types of conditions. This is a participatory process that was undertaken with Yellow Quill First Nation, which is approximately 800 on reserve individuals, but 2,000 registered, some of them living in the city and so on. There's a set of key equity issues with this community. Lack of access to the basics of modern life, such as clean water, in this case from cisterns. Runoff-based contamination of traditional watersheds that people depended on for sustenance activities like fishing. And illness from waterborne illness that was interfering with community gatherings from the contamination of water due to overflow from nearby rivers and water bodies and lakes. And flooding that caused disruption of access to chronic care centers that needed to be accessed frequently by community members with chronic disease conditions. This was work that prized a joint action type of work and a level of participation in the community that involved co-decision making. So shaping the development of the model and providing suggestions on scenarios. And it did change quite strikingly the sense of what needed to be in the model as we engaged with the community. Wade McDonald is again to be congratulated for leading this project from the modeling side. So community involvement here was pervasive. It included quantitative gathering of data. We were using LiDAR-informed community elevation maps for the community and health data involving community members. But we also had narrative types of data being collected, sharing circles, interviews, photo voice with community members, sharing concerns. And the community was involved in shaping our understanding of what data went into the model, what assumptions, in interpreting model results and findings from those scenarios. I would love to talk more about this, but this was a model thoroughly adapted to the community and captured things from cultural gatherings to dependence of water and cisterns, potentially water delivery that is itself contaminated, access to the care clinic for chronic diseases like kidney dialysis, secondary to type 2 diabetes, etc. So it was a geographic specific model that incorporated a wide variety of agents, many of which are listed here, and involved a geographic specific representation that was true to the community layout and captured the occurrence of flooding when there were high water levels in ways that could block access to community services, community events, a school, and clinics, for example. So we were looking at the interaction of waterborne effects on waterborne illness, but also the ability to seek care for chronic diseases. And captured waterborne illness status, its impact on the nursing station, together with the need for the nursing station to deal with ongoing chronic disease needs, which could be interrupted. And we had a kind of storytelling module that followed individuals at an individual level in their kind of life story in ways that could be compared with people's experiences in the community at an individual level. And I want to congratulate Wade McDonald for this. The other ABM modeling work in COVID-19 has also involved Kirk Kruger as a key developer, particularly for the Hutterite investigations. Okay, in my closing minutes here, I want to talk about traditions of patient-oriented research, community-based participatory research, participatory action research. We've been carrying on in our group participatory work across the modeling, big data, and machine learning space now for more than a decade, I think it's been. This has involved a wide variety of issues, some of them in the sphere of infectious disease like HIV/AIDS and COVID-19, but others very much in other spheres, such as mental health and addictions, diabetes and diabetic pregnancies, et cetera. I want to talk about the tradition of patient-oriented research that has enriched this work. I do serve as the lead research advisor for our center, our provincial center on patient-oriented research, or SCIPR, Saskatchewan Center for Patient-Oriented Research. And I borrowed some slides from presentations to which I've contributed to some of these materials, although not necessarily these particular slides. So patient-oriented research is work conducted with and in partnership with, critically, those with lived experience, those with conditions, and family members of them. And it seeks to involve them in the research process. The notion of patient here is defined very broadly as people who have an experience of a health issue, at risk of a health issue, and informal caregivers, et cetera. It does apply to communicable diseases, including people who are vulnerable to them. Fundamentally, it's collaborative. It deals with equity issues, and it involves communities as equal partners to academic researchers or health system parties. And it combines often knowledge with action undertaken. Now, there's a very close relationship to community-based participatory research, participatory action research, that only involves subtle distinctions that I actually don't fully understand. But these are very cognate or very closely intertwined concepts. And I do much of my work within the context of what I would call community-based participatory research. And there's broad institutional support for this. What I want to talk about, though, besides emphasizing an escalating sort of level of involvement one can have in these areas, and in quantitative metrics that one can use to kind of assess where one, how research one's planning falls on the scales of what can be achieved with participatory research, I want to talk about participatory research applied to models. And this takes advantage of the fact that, unbeknownst to many modelers in the infectious disease areas, models are profoundly important, have profound potential as boundary objects, as common points of discussion by stakeholders from different backgrounds, of stakeholders who may have little or no formal education. And models serve as a point of common discussion in cross-disciplinary teams that can involve community members just as much as they involve other academics or health system practitioners. And this is contingent on modeling approaches used and software employed. But it's been most widely applied within compartmental models or system dynamics models in the particular sub-tradition of compartmental modeling, where models are built up often initially with a causal loop diagram with the community. This from work by my colleague Peter Hoffman in India. Peter is a leader in community-based modeling efforts and has a book on the subject, community-based system dynamics. But it often then goes to a level of compartmental models that are shown with compartments reflecting the accumulations or state variables within the system. these are very tried and true processes. They've been around for decades. They're very well described in the literature with dozens, if not hundreds of publications behind them of successful engagements of communities, high schoolers, rural communities, those with little background, those with lots of educational background, et cetera. We've taken the further step of applying it in agent-based and discrete simulation models, using our visual elements as key communication tools, and using things like action charts to represent individual decision-making in the models. Representing networks and relationships is from a model of participation in a program aimed at helping those with substance use issues, homelessness, and mental health concerns, often in engagement with physicians in the context of possible stigmatization. And often we involve discrete event simulation as well that captures care service delivery particularly. Our use of these has been particularly common within hackathons with people with lived experience, with sometimes those are professionals, sometimes they're community members, where we engage with modeling teams, and those with lived experience circulate among the modeling teams and provide feedback on model deliberations outcomes in the course of a week, coming out with models at the end of the week that advance understanding. One of my colleagues comments that in 1 week like that, he took 30 pages of insights down, which he had never had before in decades of work within that sphere. Important elements here, I'll just note, include engagements that are well planned. This is not activity one goes into, just throw open the floodgates and do whatever comes. You have a set of plans for how to engage, a set of processes, and there's a set of scripts that are used and well documented in something called Scriptopedia, which is used to provide guidance for possible scripts you can deploy during these modeling engagements with communities or with those with lived experience. Often involves modeling team members having defined roles, rehearsals in advance of the actual event, and participants who might come in for multiple events that are in a row. There's often a need to be aware of power relationships. If you have a senior physician or a medical health officer in the same room as someone who's a rank and file, member of the community or an individual who is homeless, there's big power relationship differences that you need to be aware of so that the voices of the most vulnerable are not drowned out by those most who are in positions of power. What's amazing here for me is that those with virtually no background can engage with models, can often contribute to models, critique models, help improve models, and relate to the model results, particularly the storytelling capacity of models. The fact that models can tell stories with individual-based models, like agent-based models at an individual level, but other models at a level, say, of a community and its health futures. Okay, I've gone over the time I'd like to, and I want to switch to questions. I do have some very articulated thoughts on the interaction of equity issues and model structure, the importance of an individual-based lens, and needs to be very careful on how to represent heterogeneity, but I'll leave those for another time. I'd like to offer some closing comments here. So, if modeling is applied absent an equity lens, as Dr. Mishra, as Professor Mishra showed, model recommendations can sometimes widen health disparities. Sometimes the model results of what helps most on average leads us to invest in those who already have the good health and to underinvest in those who are at disadvantage, further widening the health disparities. We may come to count on digital access to digital information in a way that advantages those with ready access to digital tools and services and disadvantages those who lack them or lack currency in their tools. A textured examination of particular circumstances, whether it's First Nations reserves, whether it's Hutterite colonies or the inner city, often highlights many equity concerns and risks of stigmatization that lie at the root of the problems we may see, which are otherwise normatively approached, like low vaccination rates or people who don't present for care until too late. We view those with opprobrium sometimes, where instead, if you look at why they come about, you find systemic disadvantage imposed societally. Model architecture can help us alert us to equity-related factors, or can blind us when undertaken injudiciously. A representation of heterogeneity models is necessary, but it's not sufficient to consider equity effects. And it turns out you can actually risk harm when it's naively undertaken, when it's undertaken in a way that furthers stigmatization. Equity conscious modeling, I believe, and from our experiences in this area, benefits greatly from involving those affected, whether it's at a community level or an individual level, whether it's at stakeholders in the health system or those at disadvantage in a community. Participatory modeling confers benefits not only to the modeling project, but to society more generally by fostering community buy-in, community sense of ownership, a sense of empowerment that leads to action. And we saw that in some of our engagements, such as with La Loche Clearwater, where the modeling results led to, feedback from community stakeholders led to community uptake of things like mask use that made a huge difference in the pandemic at levels of mask use that are almost unheard of anywhere else in our province, 80% or more. There's a literature for guiding this sort of participatory modeling and research. And I provide links here in bibliography, both to participatory modeling, to patient-oriented research, and CBPR, community-based participatory research, in this presentation that will be circulated. There's a lot of institutional support for conducted participatory processes. Most provinces in Canada have organizations set up to support patient-oriented research, sometimes with their own funding vehicles, et cetera. And participatory modeling can be employed in health systems as well as in academia, as our vignettes cross both. Use of participatory modeling is not something that comes for free. It requires investment, relationship building, careful planning, use of mixed methods, agile design, and model design in interfaces that make a model accessible to community members and those who are stakeholders from outside the communities, but still carry lived experience. Those are all the comments I want to make here. I'd be glad to answer questions in the remaining time. Thank you very much.
Thank you. Thank you very much, Nathaniel. That was fantastic. Unfortunately, Jan Hong has had to leave, so I'm just going to step in. And I know Deirdre will definitely have some comments to make, but that was really interesting, and you covered so many different areas. And between your two presentations, so with Mishra, with Dr. Professor Mishra, she really highlighted this she started with this do no harm aspect, and she highlighted the fact that they're not only missing in the research in terms of consultation and contributing to understanding, but that they're not at the table either. Yeah. So as we're making public health decisions, we're making them in absence of people. So for example, in Ontario, when we've been making decisions, the people at the table have tended to be in the healthcare system, and we can see how that skews our policy approaches. So it's really interesting. And I just wanted to ask you about technology. I mean, one of the positives of this pandemic, and there aren't many, but one has been how much better we are at using things like Zoom to connect people. And I've noticed that we've been able to bring people together who previously would have not been consulted and would have had to have attended a meeting in person in order to have their voice heard. And I'm wondering, I appreciate that there is a technology disconnect between certain communities, but I'm wondering if you've noticed during this pandemic whether there has been more engagement using technologies available to us.
Yeah, thank you very much. Yes, And I can say in our own work, but also in work elsewhere in the Saskatchewan Center for Patient-Oriented Research, the pandemic's impact on access and a direct connection between researchers or health system members and patients or community members has really been affected. Some groups have been at particular disadvantage, some types of studies. So we've done quite a bit of participatory work, for example, with the indigenous, the communities within Regina, inner city communities in the Regina area, and particularly those suffering from substance use issues, HIV/AIDS, and intravenous drug use. And they're getting access to information technologies to engage in Zoom, for example, is almost impossible. We've given out phones and found that they are stolen from the individuals sometimes. Sometimes they're lost for other reasons. They have difficulty and sometimes keeping them charged. If a person's homeless, you can only imagine all the sets of issues. In one case, they were impounded by the police. This is a very serious concern. In our partnerships with Alberta partners, patient partners who had come in person to our sites to engage with modeling, we hope to involve them with Zoom, but there's real barriers because they used to be able to come to the hospital to engage in teleconferencing from hospital facilities because the research involves health system partners as well. But now the hospitals during lockdown and in some other periods are closed to people just, being able to access these resources because they might be COVID infected. So that's really got in the way of those barriers. And it's required a lot of innovative thinking of people getting together at a more informal basis, in the community, researchers with community members to try to engage in that. There's real barriers there, and for certain groups, they are profound. For others, less so. Some of those with chronic disease barriers, less profoundly. So I think it varies a bit across contexts. But there have been some conditions where I've seen us able to adapt to a remote context. And, I'd say it very much depends on the subcommunities affected. Yeah.
I think we have a question here from Jude. Jude Kong, Dr. Kong.
Thank you so much. Nate, thank you so much for the great presentation and for the great work that you have been doing. I must appreciate you for taking the lead in this bottom-up approach in research, which is an area that most scientists, especially mathematicians or computer scientists, are still getting into. And I must testify that you don't just always use it in your lab, but you try to reach out, I being one of the products, to other colleagues to help them build research from that perspective using the bottom-up approach. And I really want to thank you for that. My question is threefold, actually, based on my experience with you and trying to implement this in our community to do research in that direction. How do you identify potential stakeholders for equity-responsive health research? That's the first part of my question. And the second part will point to when you used Ethicam in harnessing data from these communities, how do you ensure that these community leaders have ownership of their data at the end? And what happened to the citizen science that you recruit in the communities, given the marginalization of these communities? And then how do we move on from here to get our funding agency to ensure that they encourage this? Because as you mentioned, doing this community research is not cheap at all. You need to compensate the stakeholders. So how do you ensure that you get NSEC on board into sponsoring this type of research?
Yeah, these are great questions, and I'll see what I can do to try to address many of them. I'm too honored by your kind comments. The truth is, I don't consider myself one of the foremost in knowledge of participatory processes. There are those whose knowledge of this area well dwarfs my own, and some modeling colleagues, such as Peter Hoffman, or Dave Anderson at Albany, Peter Hoffman's at Case Western, David Anderson at Albany, George Richardson have done wonderful work in this area. But we try to learn from their pioneering work and apply it. I will say that in terms of recruitment, the existence of patient pools are increasingly common now, both within the health system and within our provincial centers for patient-oriented research. And that is one place that we have found real help with, is turning to those who have reached out to engage with existing institutions. However, there's many stigmatizing conditions, many conditions, HIV/AIDS issues, which where public disclosure might be embarrassing, drug use, et cetera, where people are less likely to affiliate with an institution, right? They're less likely to come to an institution to sort of join a pool of partners. And there we work to reach out from other institutions that are in place. So safe injection sites, for example, working with the heads of those who know the clientele, or like we have a wonderful working relationship with Mothers to Stop the Harm, who are family members of those or people who use drugs here in the province. And those community-based organizations often are themselves very knowledgeable. Sometimes they come out of lived experience, frequently they do. And they also often have their pulse on good people in the community who can speak about different aspects of the situation. Those who have undertaken past interventions in these areas, putting modeling aside, are also great resources. So our work with modeling, so much of it has been done with Janetta Salvalaggio out with the ARCH program, the Addictions Recovery Community Health Program out in Edmonton. Look at this confluence of mental health, addictions, housing challenges, sustenance, and sometimes domestic violence, and job issues as well, legal troubles. And long before we were on the scene, she was co-running. She was one of the key people, together with Catherine Dong at Royal Alex Hospital in Edmonton, leading on these studies. And they had recruited a set of people who are frequent ED users, emergency department users, to serve as patient partners. And they were incredibly insightful for her work. And we got just wonderful advice from them in our modeling work. So I think you have to reach out to those who are already working in those areas, but also think about patient pools that are collected. As far as ownership, I think the issue of ownership has a long way to go. And in the Tri-Council 2 statements on Indigenous research, we talk about the OCAP principles, right? The ownership, control, access, and possession. And I think we have a while to go before that's fully realized. But you had mentioned our ethical tool, and I think there the key is to make sure that the community leaders are added in as co-owners of it in the platform in ways that they have total access to it, and they can dictate who else has access to it. They can also, export the data and request deletion of it in a way that they have exclusive access. But I think we have a long way to go. I'm very active in the AI equity space as well. Some of you will find talks of me online where I'm speaking about AI and equity issues. And Jude, I think you're aware of them already. And there, so much of my thinking relates to ownership of data by those in the community, and use of techniques, whether it's blockchain or homomorphic encryption, et cetera, by which they can share data for certain purposes without just giving it to the health system in a way that disempowers them, to allow for greater autonomy on parts of individuals for their health information and background information, so they can engage according to their needs. And you know, I think there's technologies that can be empowering there. I'm not sure I've done justice to your questions, but those are some elements of what I'd respond.
You did. Thank you so much.
Yeah.
Okay, unfortunately, we've actually reached the end of our session, Nate. So thank you so much on behalf of the Fields Institute and Kumar and Jan Hong and Deirdre, who was also online, just saying what a fantastic presentation it was. Thank you so much. Lots there for us to work on, and also helping really starting a foundation of framing all of these ideas and how we can build something useful that we can use as a program to address some of these very big issues. But we really have to have some of this nailed down and make sure that we as a group and a program have put these thoughts into it. And actually, if we haven't, to put our hands up and say, this is something we haven't considered, this is a limit in our research, and so that we can better prepare those communities and those who want to use our data so that they're not made vulnerable by it. And this is something we need to be ready to call out ourselves on as well. And bigger questions about how we get better representation among modelers and certainly decision makers, which is the priority of this whole program, is how we better use mathematical modeling to make these very difficult decisions in public health policy. So thank you so much, and you know, well done. It was very excellent, and we'll look forward to continuous discussion with the rest of the program.
Too kind. Thank you so much. A wide open area that everyone can advance so much. So thanks so much if it offered some value. Take care there. Honored to talk.